ممتاز. بسم الله الرحمن الرحيم. لا الصوت واطي بس برضه. بسم الله الرحمن الرحيم. لا لازم من هناك، ما ينفع. بسم الله الرحمن الرحيم. ارفع شوية، ارفع شوية. تست 1 2 3. طيب خلاص اوكي. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this holy month of Ramadan, where we are going to have this kind of scientific event to enrich ourselves with additional blessing of the month, of having more information, sharpening our skills to manage our patient better throughout the spectrum of our specialty in primary care. And as you know, ladies and gentlemen, primary care has been positioned to be one of the cornerstone of the transformation of our healthcare system in the Kingdom of Saudi Arabia. And now there is a lot of emphasis to sharpen our skills and to encourage all our colleagues to master the state of art of medicine in order to manage our patients, not only to manage, but also to go beyond the management to reach for the preventive services by screening, diagnosis, management, and then having the proper referral. Today, ladies and gentlemen, we are going to have a special event that will highlight an important part of our day-to-day encounter, which is bloating, blenching, and other symptoms that encounter many patients throughout the year, with a special focus on this month of Holy Ramadan. Before I start, I would like to introduce myself. I'm Dr. Ashraf Amir. I'm a consultant in family medicine. I'm the Executive Chief of the Executive Medical Services International Medical Center. I'm the Vice President of the Saudi Society for Family and Community Medicine. And I'm very pleased and privileged to be part of this scientific event as a moderator. Before we start, I would like to extend our thanks to Stada Company for hosting this event. And special thanks goes to the ملتقى الخبرات لتنظيم المعارض والمؤتمرات for organizing this event. And this event has been synchronized with an additional important event, which is signing the memorandum of understanding between the Saudi Society of Family Medicine and the Stada Company. So with this is going to be the first step in 100,000 miles of collaborations to enhance our capacity as a family physicians to reach for the state of art of managing our patients. Not only this, but also going to the other arm where we are going to have and deliver certain programs to enhance the capacity of our populations as community to understand exactly the things that is related to GI symptoms and other problems in general health. So we have been privileged here today, ladies and gentlemen, to have two eminent speakers who have been well known in the field of today's topic, Dr. Ihab Ali and Dr. Abdul Halim Al-Sharif. So I have been privileged to invite them, and we would like to thank them for accepting our invitations and to be part of this scientific event. So without any further ado, I would like to introduce our first speaker, Dr. Ihab Ali. He is the head of the Family Medicine Department in Medical Faqih Jeddah since 2009. He has been practicing family medicine in many countries, of course in Egypt and then in Oman. And he has been working in medical faqih and enhancing the family medicine scope of service in the Department of Family Medicine. He has a long history in clinical research and activities and educations and training of specialty of primary care and others. And he conducted many research, in fact, and he's assistant professor in analysis of results in preparation of journal articles and paper in all other research activities. So the topic that we are going to share with you today by Dr. Ihab, gas bloating, blinching, approach to evaluation and management in primary care. And we have selected this topic, why? Because we know that many of our patients, they presented to us in primary care as a raw patients, so that they come with symptoms. So how to use this kind of symptomatology in order to analyze it and come to the diagnosis and treat, and then we should understand exactly where is our limitation, where we should draw the red line after which we have to refer the patient to our colleagues in gastroenterology. So ladies and gentlemen, welcome with me Dr. Ihab Ali, and I would like to thank him for accepting our invitation today. Please.
Good evening. السلام عليكم ورحمة الله وبركاته. طبعا في البداية كل عام وحضراتكم بألف خير بمناسبة شهر رمضان المبارك أعاده الله علينا وعلى الأمة الإسلامية بالخير واليمن والبركات. First of all, I'd like to thank all of you to be here today in a very special night. Today, I'm proud to be one of the speakers in this night. Also, I'd like to thank the company to give me this opportunity to be here today with two of the eminent speakers in Jeddah, Dr. Ashraf Amir and Dr. Abdul Halim al-Sharif. And today I'll talk about one topic which is easy and difficult. It's gas bloating and bleaching. I think this is one of the most common complaints we are facing in our family medicine practice. And the challenge in dealing with such complaint that it may present in a healthy person, it may present with other functional GIT disorders like IBS or functional dyspepsia. It may also present itself as a disorder like functional abdominal bloating and functional abdominal distension, or it may present or associated with other structural disease which we need more investigation and may need to be referred to our colleagues in GIT. So today we will try to find like a roadmap and approach how to evaluate and manage patients with such complaint in primary care. Bleaching, bloating, and abdominal distension, as we said, is a highly prevalent gastrointestinal symptoms and account for one of the most common reasons for the patient visit to outpatient family medicine practice. These symptoms usually debilitating and affecting patients' quality of life and contributing to work absenteeism. Of course, bleaching and bloating differ in their pathophysiology, diagnosis, and management, and there is limited evidence available for their various treatments. We will start with bleaching. Room 4 criteria defines bleaching as an audible escape of air from the esophagus or the stomach into the pharynx. It's considered a disorder when it affecting the patient's quality of life, as it may disturb the patient's usual activity and occurs more than 3 days per week. Bleaching also can occur, as we said, in healthy individuals. It also may occur with other disorders, including GERD or functional dyspepsia or gastroparesis, pregnancy, and psychological symptoms like anxiety. Structural causes of bleaching may include hiatus hernia, paraesophageal hernia, and inpatient post-nasal fundoplication. Bleaching also can be divided into two important parts, which is gastric bleaching from the esophagus, and gastric bleaching from the stomach. Gastric bleaching occurs in up to 3.4% patients with upper GIT symptoms and is more commonly associated with anxiety. What about bloating and distension? They are different. Bloating, it's a subjective complaint, which is characterized by recurrent abdominal fullness, pressure, or sensation of trapped gas. Distension is an objective complaint, which is characterized by increase in the abdominal girth. And as we said, healthy individuals may occasionally get bloated, like after eating a large heavy meals or due to overload of fermentable foodstuffs. This type of bloating in a healthy individual is usually short and lasting few hours and may end when the individual expels stool and or gas. In most episodic bloaters, there is a very apparent circadian rhythm. Most of them will wake up in the morning with no or minimal bloating. But after breakfast and the early evening, the bloating sensation worsens and the abdominal distension becomes more apparent. Bloating and distension also may be manifestation of an organic disease, as we said, like in acute infectious enteritis, in early stage and before onset of diarrhea, and in celiac disease and other conditions associated with malabsorption, in acute or subacute bowel ischemia, in the early stages of ascites formation in patients with liver cirrhosis, and in patients with neoplastic condition, and when there is a mechanical impediment to normal flow of content along the GI tract. Bloating also usually associated with functional gastrointestinal disorders like irritable bowel syndrome and functional dyspepsia. In irritable bowel syndrome, bloating is highly prevalent manifestation in IBS patient, and usually the patient describes that he is wearing a tight clothes. And in functional dyspepsia, the bloating sensation centered in the upper abdomen and usually happen postprandial and sometimes associated with visible upper abdominal distension. What are the room 4 criteria for diagnosis of bloating and distension? For us as a physician to diagnose that the patient has functional bloating or functional distension, he should have recurrent bloating and or distension which occurring at least 1 day per week, and abdominal bloating and or distension predominant over other symptoms. And at the same time, we should exclude other diagnoses like irritable bowel syndrome, functional dyspepsia, functional diarrhea, and postprandial distress syndrome. And the criteria should fulfill for the last 3 months with symptom onset at least 6 months prior to diagnosis. Epidemiology. Incidence of functional bloating has not been assessed in large prospective studies, but the prevalence of bloating is better described. There is a large survey which is done in USA over about 2,510 patients, which report that the bloating is prevalent in 15.9% of the cases, more in female, 19.2%, and less in male by 10.5%. What about pathophysiology and the underlying mechanism of bloating? We have 4 underlying mechanisms of bloating. Impaired abdominal emitting, like in patient with defective propulsion and in patient with obstructive evacuation. Increased perception of intestinal stimuli, like in patient with sensory dysfunction and in patient with psychological factors, and in patient with altered intra-abdominal volume displacement, like patient with abdominophrenic theory, and in patient with increased luminal contents like gas, stool, liquid, and fat. And we will discuss two of those mechanisms, which is increase the luminal content and increase the perception of intestinal stimuli. Usually, bloating and distension associated with accumulation of luminal gas and or fluid. And one of the source of luminal gas is aerophagia. Aerophagia means excessive swallowing of air. And this happens by rapid ingestion of carbonated drinks and usually associated with a lag between gas swallowing and the spontaneous gas venting. And the aerophagics also usually have a bleaching, so they are also bleachers beside abdominal distension. But the main cause of abdominal bloating and distension is increased generation of luminal gas. Important gases which produced endogenously in the GIT are carbon dioxide, hydrogen, and methane. The carbon dioxide gases produced by bicarbonate neutralization of gastric acid, which entering the duodenum. But the main source of bowel gas is intraluminal fermentation of dietary and endogenous substrates, which take place mostly in the colon. In healthy individuals, 70% of the total gas present in their guts and is located in the colon. And the elimination routes of gas, 23% through the anus, transluminal, transmural disposal, and bacterial consumption. The newly generated colonic gas remains not inside the colon will depend on physical permeability of the walls, which usually modified by blood flow and inflammation, type of motor activity, exercise, which favors antegrade movement and the evacuation of the intraluminal gas, and catabolizing bacteria. Increase the gas production or decrease the gas consumption in patients with bloating and flatulence may occur due to variations in colonic microbiota. And this is one of the most important topics now, and depending on it, there is many medications now developed. Second mechanism is reflex response to unperceived stimuli. Unperceived stimuli may be modulated and upgraded by the central nervous system. Abnormal viscerosomatic reflex response can produce abdominal distension. Extraintestinal tissue within the abdominal cavity may influence the perception of bloating and the abdominal distension, like intra-abdominal adipose tissue. So rapid weight gain will aggravate the symptomatic bloating. And conversely, weight loss tend to be associated with improvement. Intra-abdominal fat accumulation may constrain bowel expansion during luminal distension by gas or fluid, and hence stimulating the visceral and the peritoneal sensory receptors. And also the adipose tissue accumulation in the epiplon or mesentery may have a pro-inflammatory action by release of inflammatory cytokines, which can contribute to intestinal hypersensitivity. And also, bloating and distension usually increased in a specific periods, like pre-ministerial period, and we all know about the stress in this period. And maybe the cause is the enhancement of visceral sensitivity, which happen under the stress during the period, and usually also increasing by meals. So you will find that the patient or the individual may have bloating and distension usually after eating large meals and the postprandial period. And the gas and the chemo pooling, which can enhance the gut sensorial stimulation during digestion. Now we are reaching to the most important part in our lecture today, which is the clinical evaluation. How to deal with a patient with abdominal bloating and distension. Functional abdominal bloating and the functional abdominal distension should be diagnosed based on the following 3 key features: clinical history, physical examination, and diagnostic studies. But before we are going through this, there is a very important part of the consultation. On it, the success of management will depend, which is establish a trust relationship with your patient. A trusting therapeutic relationship is essential for the patient to understand and accept the biopsychosocial model of functional gastrointestinal disorders and to be confident that his physician evaluated him for other conditions and to accept the limitation of therapy and the incremental improvement of symptoms and to engage in effective self-management. Patients with functional gastrointestinal disorders usually believe that they are not appreciated enough. They are not appreciated like patients with structural condition like inflammatory bowel disease or infections. So it's very important to listen to your patient carefully, very important to acknowledge his symptom and to give him the care he deserves. Second part, you should exclude the alarm symptoms. Why? Alarm symptoms, the presence of any of it, means that your patient in need for more evaluation and require additional testing. And the American Academy of Family Physicians put all the alarm symptoms in one table, starting from presence of abdominal mass, dysphagia, extreme diarrhea, fever, gastrointestinal bleeding, jaundice, lymphadenopathy, new onset symptom in patient 55 years or older, odynophagia, symptoms of chronic pancreatitis, symptoms of gastrointestinal cancer, including family history, symptoms of ovarian cancer, including family history, tenesmus, unintentional weight loss, one of the most important alarm symptoms, which if found in your patient, you should investigate him for serious condition and persistent vomiting. Why it's important to rule out alarm symptoms when you are dealing with patient with bloating or distension? Because if any one of these alarm symptoms present in your patient, that means he is in need for additional investigation and may need to refer him to the gastroenterology. History. Your patient should be asked about the chronicity, waxing and waning of symptoms, temporal relationship, precipitating or aggravating events, recent illness, and psychosocial stressors. And also the relationship of the bloating and distension to diet and presence of symptoms suggestive of other functional gastrointestinal disorder like IBS or functional dyspepsia and presence of any of the alarm features as we said before. And one of the most important part in history is dietary history. Physicians should ask about timing and pattern of meals. Larger or less frequent meals, gulping of food, poorly chewed food, and the content of food also is important to rule out or for differential diagnosis of the abdominal bloating and distension, like gas-producing food, artificial sweeteners, caffeinated or carbonated beverages. Also, American Family Physician collect the possible causes of functional gastrointestinal disorders and its effect on the GIT in this table. Artificial sweeteners, like sugar-free gum, can lead to bloating, but often with diarrhea. Caffeinated beverages, like coffee or soda, can cause bleaching and diarrhea, but less likely to cause bloating because it can decrease the lower esophageal sphincter pressure, which causes bleaching. Carbonated drinks, like soda and other carbonated beverages, can lead to excess gas and bloating. Eating habits, one of the most important causes of bleaching, bloating, or gas, like gulping food, eating quickly, and not chewing food good, or routinely chewing gum, all those causes can leading to bloating or bleaching. Over-the-counter medication, especially the antacids, which containing magnesium, can lead to diarrhea. Size and timing of meals, large or frequent meals, or meals eaten late in the day can lead to bloating with distension or dyspepsia. Specific foods like beans, fiber, fructose, lactose can lead to gas accumulation. After the history of your patient, you should categorize the symptoms. And there is two important questions which help you to localize which distinct level of GIT tract is involved. First question, can you eat a full plate or food? Second question, do you regularly have a good bowel movement? And American Academy of Family Physicians categorize the symptoms into three categories: gas and bloating, gas and bloating with constipation, and bleaching. Gas and bloating, here the timing is important. If the symptoms onset less than 30 minutes after eating, that means we are dealing with gastric bloating. And the differential diagnosis of this is functional dyspepsia, gastroparesis, disorders of accommodation, and gastric outlet obstruction. And in this case, you may need to do upper endoscopy or glycated hemoglobin to rule out gastroparesis, and gastric imaging studies also may be needed. If the symptoms onset more than 30 minutes after eating, that means we are dealing with a small bowel bloating. And here the differential diagnosis is irritable bowel syndrome, celiac disease, dietary causes, small intestinal bacterial overgrowth, SIBO, and here also you may need to do celiac serology, hydrogen breath testing to rule out SIBO. Bloating, gas bloating with constipation. Bloating with constipation, here you should rule out chronic idiopathic constipation and constipation predominant IBS, dysnergic defecation, which may be due to pelvic floor dysfunction and slow transit constipation. And here you may need to examine or do rectal examination and do also thyroid function hormone, calcium, colonoscopy, anorectal manometry, colonic transit study. Bleaching, and the differential diagnosis of bleaching can be gastric bleaching, supragastric bleaching, and aerophagia. And usually in bleaching, there is no testing is necessary. Physical examination. As we said, abdominal distension can be seen as a visible increase in abdominal girth. Pelvic and rectal examination should be performed when appropriate. Evidence of partial bowel obstruction can be discovered in physical examination or organomegaly, which may need further evaluation. Laboratory and radiological image will depend on the finding from the history and physical examination, like CBC, celiac disease, celiac test, intolerance to lactose, fructose, and sorbitol could be evaluated with breath test. Jejunal aspirate also may be needed in some cases. Radiological image also will depend on the finding, like abdominal X-ray, CT scan, and abdominal MRI, which can be repeated because it doesn't involve radiation. How to treat? This time we are going to American Gastroenterology Association. American Gastroenterology Association making like an algorithm to how to deal with patient with abdominal bloating and distension. First question you will ask to your patient, is constipation present? If yes, here you should take detailed history with rectal examination, and also you should exclude IBS constipation or chronic constipation depending on the room 4 criteria, and you may need to do anorectal manometry to diagnose pelvic floor dysnergia. Treatment, you will treat first the constipation, and biofeedback therapy will be needed if there is dysnergic defecation present. If no constipation, second question, we will ask about the food intolerance. If there is food intolerance, here we will investigate for carbohydrate intolerance, celiac disease, or food allergies, or non-celiac gluten sensitivity. And the treatment will be carbohydrate or food map restriction, gluten-free diet for celiac disease, or if suspected non-celiac gluten sensitivity. The third, if there is no food intolerance and there is no constipation, we will rule out the alarm symptoms, like as we said before, vomiting, weight loss, bleeding, and the diagnosis and the investigation will depend on the finding. Here we should consider to do CBC, metabolic panel, and other lab if needed. Also, we may need to exclude structural abnormality by doing ultrasound, CT, MRI, and also we may need to do motility studies to diagnose gastroparesis, CIB, or other motility disorder, and the treatment here will depend on the clinical finding, and prokinetics may be used in this patient for motility disorders. If there is no alarm features or symptoms, here we will rule out SIBO. If SIBO risk factor present, we will need to do hydrogen-based breath testing with glucose or lactulose or small bowel aspirate, and if SIBO present, we will treat with antibiotics. Lastly, we should rule out abdominophrenic dysnergia or visceral hypersensitivity, and if present, we should treat using diaphragmatic breathing, central neuromodulators, brain-gut behavioral therapies. Treatment of functional abdominal bloating and functional abdominal distension. The most important part of treatment is dietary therapy. Dietary therapy has two distincts in this patient. First, avoid food intolerance. Second, reduce fermentation of food residues. Excess fermentation may occur because of high intake of gas-producing foods, small bowel malabsorption, variation in the metabolic activity of the microbiota. So a diet low in fermentable components are associated with major and measurable reduction in the flatulence, abdominal distension, and improvement in well-being. Food map restricted diet is also a cornerstone in treatment of such patient. But to do it, that means you should exclude common components of normal Western diet. And I think the benefit will happen when our patient long-term adherence to this food map restricted diet. And this is an example which food to avoid, which food to enjoy when you are prescribing low food map diet for your patient. Microbiome modulation, like reducing gas-producing bacterial species and modifying their metabolic activity. Probiotics, the probiotics modulate intraluminal fermentation, mucosal inflammation, and visceral sensitivity. Probiotics would seem an attractive option for the treatment of bloating. However, clinical efficacy of probiotics remains measured up till now. Prebiotics, which are non-absorbable, fermentable substrates, and they include the proliferation of beneficial microorganisms. Initially, these substrates increase gas production, but after 1 to 2 weeks adaptation period, gas production decreases and the abdominal symptoms may improve. And this is the difference between probiotics and the prebiotics. Probiotics are good bacteria, living microorganisms, feed of prebiotics, restore and balance the gut flora, but prebiotics is non-living plant fibers serve as food for probiotics and help healthy bacteria to grow and flourish in the gut. Both are necessary for healthy body and mind, and we need the right balance for each to ensure the gut can function optimally. OTC and natural remedies, we have numerous agents are available like activated charcoal, simicicone, kiwi fruit extract, and magnesium salts. To conclude our lecture today, abdominal bloating is a subjective symptom, but distension is characterized by an increase in abdominal cavity. Possible underlying mechanisms of bloating may be impaired abdominal emitting, increased luminal contents, altered intra-abdominal volume displacement, and increased perception of intestinal stimuli. A diet low in fermentable components are associated with a major and measurable reduction in flatulence, abdominal distension, and improvement in well-being. Treatment of functional abdominal bloating and distension may be changed according to the underlying mechanism, and thank you.
Thank you so much, Dr. Ihab Ali, for this wonderful presentation that you take us on a journey for approaching a patient with abdominal bloating and belching and distension. And it was very nice to enlighten the recommendations of the American Academy of Family Physicians in eliciting the history, taking the symptomatology, and then the approach to the diagnosis and the management as well. I think it was very interesting for us to take the tables which have highlighted, to be in front of us in our clinics, to approach those patients professionally. So now we are going to move to the second speaker. But before that, I would like just to mention that we are attended with virtually attendees, more than 900. So I would like to encourage them to put their questions in the Q&A box. So in order to have it at the end of this session, so we'll have the question from the audience here physically and virtually from the audience online. So now we'll move to the second speaker, who's Dr. Abdul Halim al-Sharif. He's a consultant gastroenterology and hepatology, head of the endoscopy unit in Dr. Samir Abbas Hospital in Jeddah, assistant professor of gastroenterology and hepatology department of Al-Azhar University Hospital in Cairo. And he's a research associate in gastroenterology and hepatology unit, Kyoto University Hospital in Kyoto in Japan. And he has a wealth of experience in the field of gastroenterology and a lot of experience in the field of the topic that we are going to highlight today. So the topic is going to be translating evidence to practice using sympathetic cone to reduce flatulence. So on your behalf, ladies and gentlemen, I would like to welcome Dr. Abdul Halim for being with us here today. I'm very sure this will be another interesting topic.
بسم الله والصلاة والسلام على أشرف الخلق والمرسلين. First of all, I would like to thank you all for your attendance, and I would like to thank the inviting company, Professor Ashraf Amir, Professor Abdul Hafiz, for giving me the chance to say my lecture today. And briefly today, I'm not going to talk a lot because we want to join Suhoor so early, so briefly we're going to talk about the flatulence in IPS patient and the role of the simicicone and other treatment options to reduce the flatulence. So, as you know, IPS remains one of the most common GID disorders seen by clinicians that greatly reduce the patient quality of life, and they usually affect the economy. And according to a study published in the Nature 2020, they state that the global prevalence of IPS is approximately 11%. And another study published in Saudi Arabia, 2019, stated the same prevalence, that is almost 8.8%, followed by another study published in Saudi Journal of Gastroenterology in 2021, which almost the same prevalence, which is about 8%. IBS is categorized based on the Bristol scale into IBS with predominant constipation, presented with type 1 and 2, IBS with predominant diarrhea, presented with 6 and 7, mixed type, and undetermined type. In IBS, the prevalence of IBS with predominant constipation is more common in females, while the prevalence of IBS with predominant diarrhea is equal in both gender. And IBS is, we usually see the IBS in 4th and 5th decades of life, and about 30% of patients need to seek medical advice. The IBS market size have been increased in the last decade and expected to be increased in the coming years, with a huge economic burden reaching up $30 billion per year, including direct cost, prescription, investigation, medical visits, or indirect like absenteeism or decreased work productivity. We have many symptoms of IBS, mostly our GRE symptoms or maybe extraintestinal symptoms, but perhaps the most common symptom is abdominal distension. And we found that abdominal distension or bloating are present in 92% in patients with IBS with constipation. And the presence with the average prevalence is 83% in IBS with predominant diarrhea. And although we found high prevalence of bloating symptoms, we don't find it mentioned at all in room 4 criteria. As Dr. Ihab mentioned, room 4 criteria defining IBS as recurrent abdominal pain at least once per week in the last 3 months, associated with 2 or more of the following criteria related to defecation, associated with either a change in the frequency or in the form of the stool. So they didn't mention bloating in the room 4 criteria. Also, the British guidelines, when they defined the IBS, stated that abdominal pain or discomfort in association with altered bowel habit for at least 6 months in the absence of alarm symptoms or signs. So they didn't also mention bloating in the definition of the IBS. So I still believe that bloating should be mentioned as a core symptoms in the definition of IBS. And perhaps the question is why bloating occurs in IBS patients from the start. So we have many causes and triggering factors. Maybe the most 2 common triggering factors are stress and dysbiosis. And when we have a stress, either physically or, this doesn't work, okay. Either physically or psychologically, this leads to the release of the corticotropin releasing hormone from the hypothalamus, ending up into increase the cortisol secretion from the adrenal glands, that leading to changing the microbiota profile, leading to alteration in the permeability that end up into dysbiosis. And when we have a dysbiosis, this is what leads to bloating. And also we found that when we have dysbiosis, this leads to increase the cytokine release, especially the interleukin-1p and tumor necrosis factor alpha. And when we have this 3 factor, changing in the microbiota profile, alteration in the permeability, dysbiosis, when we have these 3 factors gathered, this is what leads to altered cognition, nociception, and behavioral changes. And this is again leads to stress. So it's like a vicious circle, a condition to what we called the gut-brain axis, like both can affect each other. One of the causes of bloating is visceral hypersensitivity and gut dysmotility, that we found that we have marked abdominal contraction, especially colonic contraction. And this leads to increase the gas trapping, prolonged the colonic transit time, which increases the bacterial fermentation, dysbiosis, and this will definitely lead to bloating. When we digest some certain kinds of carbohydrate to what we call the non-absorbable carbohydrates, this leads to increase in the fermentation of the bacteria and bacterial fermentation. This leads to increase the gas production, short-chain fatty acids that end up into bloating and abdominal pain. So how to manage? According to the American guidelines, they provide us with to what we called a positive diagnostic strategy. And in this strategy, we depend mainly on the symptoms of the Rome 4 criteria. As we mentioned before, related to defecation, change in the frequency, change in the appearance. And we minimize the unnecessary texting. So we depend mainly on these symptoms. Also, the Japanese guidelines support the American guidelines, and they stated that we can count on the Rome 4 criteria for diagnosis of IPS. But is that enough? Because we usually see the bloating every day. All the time we see abdominal pain, changing in the frequency, form of the stool in many diseases, not only the IPS. We even found it in IBD, we found it in even the colonic cancer, celiac disease. So is that enough for diagnosis of IPS, especially IPS? Until we got the British guidelines in 2021, which stated that to make a positive diagnosis of IPS, we should have symptoms, yes, but also we should have good history taking, including medication, comorbidities, non-gastrointestinal disorders, other extraintestinal symptoms. So we have to keep in mind asking about other symptoms. Also, we have to make a baseline investigations, including celiac, IBD, even the investigation to rule out colonic carcinoma. And when we gather these issues, including symptoms, history taking, investigations, we can, at the end, make a positive diagnosis of IPS. So treatment usually include lifestyle changes, pharmacological treatment, psychotherapy, and other treatment options. Starting with the lifestyle changing exercise, we found that it accelerates the gastrointestinal transit and increase the microbial diversity, so it improved definitely bloating and intestinal gas clearance. And the British and the Japanese guidelines support exercise and stated that it's one of the first-line therapy in patients with IPS. And a systemic review of 14 randomized studies reported that 1 hour of yoga, half an hour of walking or aerobic exercise every day for 4 weeks, this is definitely can improve the IPS symptoms. Regarding diet, we have the IPS pyramid, which depending mainly on the healthy eating habits, try to focus more on the vegetables, decreasing the milky product. And also we have some or many randomized controlled study that support to what we call the food elimination diet based on IgG antibodies. And this is, by the way, a very common test that is being commercially used in the last couple of years. But all the guidelines, the British, Japanese, American, are suggesting against this test because the accuracy is not that expected. One of the diet, which we called helpful diet, is a soluble fibers, because we found that it increased the water content and resist the colonic fermentation, thus decrease the bloating. And we definitely want to exclude the insoluble fibers that may be increasing the gas production and bloating. Also, all the guidelines suggest to use the fiber diet, especially the soluble fibers, starting with a low dose and build up gradually. And as we mentioned before, this is the list of the food that we have to avoid, and this is the list of the food that we have to take care of, which what we call the low food map diet: fermentile, oligosaccharide, disaccharide, monosaccharide, and polyols. When we take a food map diet, this is increase the fermentation, increasing the bloating, short chain fatty acids, and finally distension. So when we avoid this kind of food, the bloating definitely will decrease, which gained popularity in the last couple of years. And British guidelines and American guidelines consider the low food map diet as a second-line therapy in patients with IPS. We don't have any data regarding the Japanese guidelines. Simethicone could be one of the options in treating bloating. And as you know, simethicone is a silicone compound that decreasing the surface tension of the gas bubble, so resulting in dispersion of the gas bubble, allowing the removal from the GI tract. And a randomized placebo-controlled trial using simethicone 300 milligram, they found marked improvement either in abdominal pain and bloating in comparing to placebo. And another European study, which is a randomized double-blind, also placebo-controlled study, make a combination between the simethicone and one of the probiotics, and they found also the same result with marked improvement in bloating and abdominal pain in compared to placebo. Although we have a clear guidelines regarding the use of the simacicone either before chronic preparation before colonoscopy or chronic preparation before capsule endoscopy, and although we have many studies confirming the efficacy of the simacicone as one of the treatment options for bloating in IPS patient, still no guidelines available. One of the treatment options, probiotics, and as you know, probiotics improve the dysbiosis, so it interferes with this algorithm, and definitely when we interfere with the dysbiosis, this will improve the bloating. And it was for the first time, the British guidelines in 2021 put the probiotics as one of the, not the second, the first line therapy for patients with IPS, and they stated that treatment should be taken for at least 3 months. Also, the Japanese guidelines support the British guidelines for probiotics, and they stated that probiotics are effective in treating IPS patients and with a strong recommendation. We usually have the American guidelines, which all the time antagonize the other guidelines, which suggest against the probiotics, and they stated that studies are still small, single-centered, and doesn't follow up the rigorous standards set out by the US FDA. One of the treatment options is antispasmodics, which remain one of the most frequently used treatment for IPS patients, and definitely improve also the bloating because it reduces the colonic contractions. And perhaps the most two common antispasmodic is mebivarin and otulonium bromide. And as we mentioned, it reduces the abdominal contraction, so it's improving the gas trapping, minimize the colonic transit time, and bacterial fermentation, so improve dysbiosis and improving bloating. And all the guidelines also suggest to use the antispasmodic as one of the treatment options for patients with IPS. Another group is the prokinetics, especially the tigacerode and prucalopride. And we found that they improve the gastric emptying, improve the esophageal peristalsis, so they improve bloating also. And all the guidelines suggest to use the prokinetics as a second-line therapy in patients with IPS with predominant constipation. We have a new group, which not that new, it's like maybe 2 or 3 years in the market. We call the intestinal secretagogues, including lubiprostone or linaclotide. The lubiprostone is the chloride channel activator. It leads to influx of the chloride ion into the lumen, and this is followed by the positively charged sodium ions, followed by water. So increase the intestinal motility and stool passage, and also improving bloating. Linaclotide acting like the same mechanism, but the main difference that is stimulate the cyclic GMP, stimulating the protein kinase 2, and again stimulate the chloride channel to leading to influx of more chloride ions. Again, we have a full recommendation regarding all the guidelines to use the intestinal secretagogues as one of the treatment options, second-line treatment for patients with IPS with predominant constipation. Rifaximin is bacterial antibiotics, bactericidal antibiotic, which also prevent the dysbiosis and also improving bloating. And also all the guide, once again, suggest you the rifaximin as a second-line therapy for patients with IPS with predominant area. Tricyclic antidepressant, we found that it improved the visceral pain. It also interfered with the stress, so interfere with this algorithm, so it improved the dysbiosis, and also has a small muscle relaxation, so it also minimizing the colonic contraction, so it also improved the bloating. And the guidelines recommended to use the tricyclic antidepressant as the second-line therapy for patients with IPS with predominant area. Lastly, we have the iloxadoline on the market by the name of Vibrezi, which is a mixed opioid receptor drug. This drug stimulates the mu opioid and kappa opioid to the right side, which leading to slowing down of the visceral motility and also reducing the visceral pain and contraction. So it also can improve the bloating. But it's also one of the benefits of the iloxadoline that it antagonizes the delta opioid receptor. So this is attenuate again the mu opioid receptor, so decreasing the severe constipation that may happen as a side effect of stimulating the receptor. So this is mimicking the normal and physiological movement of the colon. And also, the British guidelines and the American guidelines suggest to you the loxodulene as the second-line therapy in patients with IPS with predominant area. Other treatment option could be psychological therapies, peppermint oil, narcotics, anti-allergic drugs, bile acid sequestrant, fecal microbiota transplantation. So, in conclusion, life is so short. Enjoy your life with delicious meal and forget about IPS. Thank you. اتلخبطت مش عارف انهي بتاعي تاخد ان ده ده بتاعي
اوكي تمام. طيب تفضل دكتور عبد الحليم. Yeah. Okay, thank you very much, Dr. Abdul Halim, for this one nice presentation. And I would like to ask Dr. Ihab to come on the stage. So I would like to open the floor now for the questions from the audience. Question? Dr. Abdul Hamid? Okay. In fact, we have received some of the questions from the audience who were virtually attending with us. There is a question, association of aerophagia with bloating and belching. The aerophagia, those who are swallowing a lot of air, during the talk or during the way they eat. Does this kind of habit aggravate the bloating, and it could be modified to have a proper way of eating? Anyone?
Yes, Dr. Ashraf, this is indeed one of the main causes of bloating. But to be honest, we found these symptoms mainly if we have too much stress. The main cause of aerophagia, of course we have different causes, but the main cause, we found it more clinically in the OPDs when we got a high stress patient or some patients who suffer from psychological conditions. And I think the main treatment of these patients, sometimes we use like reassurance methods. Sometimes we depends on some diet habits to decrease. We try to inform the patient just to slowing down with some habits and some recommendation regarding the food, especially in Ramadan. And one of the also options is the treatment, either by using the anti-inflammatory medications up to using antipsychotic treatment.
Okay, very well. Okay, there is a question, Dr. Abdul Halim. Now we are in the era of new molecules has been introduced in the management of diabetes and obesity, the GLP-1, the semaglutide and tirzepatide, which decrease the gastric emptying time. So many of the patients, they come with nausea, vomiting, constipation, diarrhea, and abdominal bloating as well. Can we use the silicone in these kind of patients along with other modalities that we are using?
Yes, definitely we can use. But if you notice, Dr. Ashraf, that most of the patients seeking for, which I see every day, my colleague, I don't know if you can also tell me your experience that most of the patients taking GLP-1 agonists is not really, it's taken for obesity.
Yes, absolutely.
Not for diabetes.
Yes.
Because until now we don't have, I think, a clear guidelines in Saudi Arabia to use the GLP-1 as an obesity. But Cytosicone can definitely improve the bloating, but will not improve the nausea. As you said, it's slowing the
gastric emptying. Yes.
So, for example, instead of like we have normal gastric emptying between 4 and 6 hours, and we have a gastric emptying reaching up to 18 and 20 hours.
Yes.
So you feel like the food is not in my chest. So Cytosicone have some rule that it can improve the bloating symptoms, but it will not, I believe it will not have any role in improving the nausea.
Okay. Okay. Dr. Ihab, you said elegantly the functional GI disorders The biopsychosocial model has to be implemented as a family physician. If you just can highlight this point.
Okay, Dr. Ashraf, as a family physician, we are not dealing with the physical side of the patient. We are dealing with different or comprehensive patient. Like we are dealing with the biopsychosocial model. We all know that most of the functional GIT disorders related to the stress. You will find patients with IBS, at the same time we have functional dyspepsia, at the same time we have functional floating. So you will find all of the symptoms going about the brain-gut interconnection. So it's important not only to take your patient from the physical side. No, it's important to go through your patient to his social side, to his psychological side, because it's like a comprehensive care of the patient we are doing in families. And so the role of like antidepressant, like Dr. Abdulhalim said, and tricyclic antidepressant and SSRI in treatment of IBS, it has a very important role because one of the important causes in patient for functional dyspepsia, functional GIT disorders is stress and psychological problem.
Absolutely. I think one of the very unique modalities in family medicine is the biopsychosocial model, because underneath all the chronic disease and quality of life which is impaired by certain disease, if you just implement this kind of concept, you treat the body, but addressing the psychology and the social impact of the problem. When we talk about bloating and functional dyspepsia and GI disorders, definitely there is some psychological elements. We get some patients who are depressed with all the criteria of depression or anxiety, especially with irritable bowel syndrome and so forth. But again, there is some impact on the social activities and social engagement. So I think this model has to be kept all the time, not only for us as a family physician, but across the board with all the doctors. There is a question, the combination between the probiotics or the prebiotics or probiotics or both with simethicone. How is this combination is effective, and what are the symptoms or the disorder that we can use these kind of combinations?
There's many studies. Many of them are randomized, double-blind, placebo-controlled studies. One of the studies we mentioned in the literature that we have a combination with the simethicone together with the probiotics, we get the maximum effect. Because both are doing or acting in different mechanisms of action, but both leads to decreasing the bloating. Maybe perhaps the probiotics acting mainly with the desmolysis, so it's improving the desmolysis. And as we said, the simethicone acting locally by dispersing the gas bubble and dispersing it like small pieces, and this is will get rid of it very easily through the GI tract. So if we combine these two medications with two different unique mechanisms of action, so this will definitely improve the bloating and hypertension.
Okay, thank you so much. In fact, we have been privileged today to have both of you represented two levels of care. One is primary care and the other one is secondary care. So my question is, how do you position simethicone in primary care and secondary care? What is the selection criteria to use this kind of medications? What are the symptoms of the patients? What is the profile of patients that you have it in primary care and then in secondary care? And for you, Dr. Abdulhalim, when to refer patient to gastroenterology?
Like I said, Dr. Ashraf, when we are dealing with a patient with bloating or distension, we are dealing with a challenge. The challenge here is that it may happen normally in a normal person. It may happen with other GIT disorders. It may happen with a structural disease. So it's important to deal with your patient by taking history, physical examination, and investigation to rule out any structural problem, to rule out any other functional disorders, and also to diagnose that he has a functional dyspepsia or functional distension. If your patient is diagnosed as he has like functional dyspepsia or functional distension, the main part of treatment is diet. You should put him coming from the foodstuffs in the abdomen and the bacteria acting on it. And the second step, like we said, is probiotics, prebiotics, and cytosine. But when we are going to refer our patient to gastroenterology, this is also one of the principles of family medicine practice, which is continuation of care and also coordination of care. Coordination of care, that means that we are, as a family physician, we need to decide when to refer our patient. The first and important part is presence of alarm symptoms. We should search about alarm symptoms because it's important. Alarm symptoms like unintentional weight loss, like dysphagia, like bleeding, upper or lower, like persistent vomiting. Presence of any of alarm symptoms in our patient, that means that our patient needs more care. Our patient needs to rule out a serious condition may be happening. We may need to do upper or lower endoscopy or refer our patient to gastroenterologist to decide which is the next step we will do to the patient. But if we decide or if we diagnose our patient that he has functional bloating or functional distension, here the role of cytosine may come that it can help with the diet control, with the probiotics and probiotics to control this symptom.
Okay, and the dosing? The dose of Sednathicone, 300 milligrams.
Yeah, it's 300 milligrams may be taken every 6 hours, I say.
Okay.
Yeah.
500, yeah. Okay. Right, Dr. Abdul Halim?
Regarding the secondary referral, we found that gas bloating in every disease, almost every disease. We can mention with trust that 90% of the GI disorders have gas bloating. So the company that's going to say, we talk about bloating, it's very difficult to
Yes.
in one lecture.
Absolutely.
That's why I responded to you.
IBS. Yeah.
I'm very concise to IBS because it's really very difficult.
Yeah.
So cytosine is one of the treatment tool which really counter that. But to be honest, as I mentioned, it's one of the tools, but not the main tool. And until now, we have many studies, many studies. Some of them is randomized controlled studies, and most of them are mentioned and highlight the effect of the cytosine in controlling the bloating in different GI diseases. But still not mentioned in the guidelines. But definitely counted in the tertiary treatment for GI patients.
Okay. How about the discrepancy between the American and the British guidelines in the management? So which one do
All the time.
they always say the guidelines are handrails. It's not a railway. So we have to develop our own clinical expertise. Yeah. So how do you manage this?
This is one important one.
Yeah.
As we mentioned before, for example, when we counted about the diagnosis of the IBS, so we found that the British guidelines are more concise, more informative, easy to handle, comparing to the American guideline that counts mainly on symptoms only of the rheumatoid arthritis. Because in my opinion, what it should be mentioned, how come the most common symptoms, the IBS, never mentioned in the definition. So sometimes, yes, we should have our own guidelines to practice.
Yes, of course. Okay, do we have any question here? Dr. Abu Nawas, please go ahead.
Thank you very much. It's very constructive to come talks and had a lot of certain things regarding the lifestyle different from Europe and the States. We have the hot weather here, not everything, and different kind of food, which is this will affect my direct question regarding the time in the continent of the rectal evacuation, i.e. with the constipation. Does it affect or it reflects to the other symptom? Or if we have it here, we have a constipation in very high percentage. Is there anything in the studies deal with this kind of regulation regarding IBS? Because this could be considered sometimes as a cytosomatic presentation. Thank you.
This is a tough question. Regarding, we had some patients, we called it slow transit patients. Sometimes we have patients with, of course we have normal variations between a patient to another, but this is one of the terms and one of the conditions which is already established, that we have some patients to what we call slow transit. It means that physiologically, usually we take, for example, certain times for complete evacuations in the journey between the mouth and the anus. But some patients have more time. That's what we call the slow transit time. So when we have a slow transit, this is will make the patient more vulnerable to more fermentation. So again, gas becomes more. So this is true. But maybe this is the role of the buying companies, the Sandiscone, and we strongly use the Sandiscone in this patient with slow transit time. Typically improve the loading with adding some medications like probiotics, doing some house therapy, walking a lot, using some diet habits together, all together can help the patient to relieve his symptoms.
Okay. We have one question here, please. Mike.
I have 2 points I need to ask of the first. He mentioned that persistent vomiting is an alarming feature we need to take care of. For how long for vomiting is to continue to consider it as persistent? This is first. Second, a lot of our colleagues consider Helicobacter pylori is a reason of fatness in the gluten. Okay, sorry. Is it true we need to screen for Helicobacter pylori in case of gluten, and if it's possible we need to give medicine or eradication course or not?
First question,
First question is about the persistent vomiting you mentioned. Persistent vomiting as an alarming feature. For how long it needs to continue to consider it as persistent? استمر قد ايه؟ فترة قد ايه؟ عشان نعتبره persistent.
Persistent vomiting, that means vomiting not responding to treatment. We are trying to give the patient treatment, that the treatment failed to control the vomiting. So it will depend on the responding of the vomiting to the treatment. Other symptoms, it is not only about vomiting, as we said, it's about many features we are searching about it, like anemia, unexplained anemia, weight loss, bleeding, upper blood, any alarm symptoms present in your patient, that means you should exclude the underlying disease. About distant treat, this is important in patient. You will suspect like dysfunctional dyspepsia. When we are dealing with patient with dyspepsia, the distant treat is an important step. Like if you will give your patient PPI for 4 to 6 weeks and he is not responding, then test for Helicobacter pylori. This is recommended by American Family Physician, and it's an important step. If your patient complaining of dyspepsia more than 4 weeks and not responding to the first trial of PPI for 4 weeks, so you should exclude Helicobacter pylori by distant treat for it.
Okay.
Just I would like to ask an important question, because I noticed in this worthy lectures that one of the causes of the irritable bowel syndrome and another symptoms may be the food intolerance. I need to know or to dig deep to understand about the types of the food intolerance and the prevalence here in Saudi Arabia, or the most common causes of the food intolerance. Is there any clinical guidelines or track we have to follow about treating with such cases in our community? Thank you.
further recommendations until now regarding the guidelines regarding food. As we mentioned in the lecture that the 2 couple of years before, we have a clear recommendation with all the guidelines regarding using the low food map diet, which gained popularity in the last years. And they listed some kind of food with a big list that this food you need to avoid because of decreasing the bloating, fermentation time, and they also mentioned a big list that you can use instead. So, following this recommendation, the idea about the food map diet. Yes, exactly.
Is there any medication recommended for this, plus the diet restriction or the
Regarding the diet?
Yes.
Yes, we mentioned too many medications in the lecture that we can use starting from the pharmaceutical, going to the probiotics. We can use the anti-tricyclic antidepressant, new groups with cretagogues, we call them spinal cretagogues like linaclotide, prochloride. We mentioned also other treatment options. So we have many drugs in the treatment for the IBS patient with bloating or changing bowel habit. Yes.
Okay, any questions? Any more? Okay, I think by this we will come to the end of this scientific event, and I would like to thank on your behalf, ladies and gentlemen, Dr. Ihab Ali and Dr. Abdul Halim Sharif for their wonderful contribution for the success of this scientific gathering. And now we have learned a lot about the functional GI disorders in terms of abdominal bloatings and belchings, and how we can position simethicone in the management of patients with this kind of symptomatology, with a special focus on those patients with irritable bowel syndrome. So I would like to thank the Saudi Society for Family and Community Medicine for having this scientific event under the umbrella, and special thanks for Strada Company for sponsoring and giving us opportunity today to be together. So special thanks goes to Fexis for organizing this event, and I wish that we have delivered something of value for all of you as a primary care physician, and hopefully that we can carry all this wealth of information tomorrow onward to put it in the real world practice and to manage our patients in early stage, identifying what are the red flags and using the biopsychosocial model, using the simethicone to manage our patients with this kind of all components. Inshallah, we will be leading the way to success to manage our patients with functional GI disorder. So I would like to announce that we will be having suhoor, inshallah, in the third floor, and the certifications for attending this scientific session will be sent to you through the email. Thank you so much for being with us, ladies and gentlemen, and wish you a very good night. Thank you so much. We'll have a picture here, or group pictures on the stage, please.
Where's the heck over the sound?